All right, we're going to talk about the benefits of cardiac rehab now. And Dr. Michael Miedema is a preventative cardiologist with the Minneapolis Heart Institute. Dr. Miedema completed his cardiology training at the University of Minnesota, and he obtained a master's in public health from the Harvard University School of Public Health. His research interests include cardiovascular risk assessment, how to best allocate preventative cardiovascular medications, and the optimal heart healthy diet. In both 2020 and 2019, Dr. Miedema was named a top doctor in Minneapolis-St. Paul magazine. We're excited to have his presentation, and sit back. We're going to discuss the benefits of cardiac rehab.
Hello, good afternoon. My name is Michael Miedema. I'm the Director of Cardiovascular Prevention at the Minneapolis Heart Institute. And today we're going to spend some time talking about cardiac rehab. And we're really going to focus on three things. We're going to talk about why we need cardiac rehab, some of the details about cardiac rehab programs, and then just finish up with some of the educational components in the rehab programs that they'll teach about when you participate in one of these programs. So in terms of why we need it, deaths from cardiovascular disease rose pretty substantially during the last century and peaked around the 1970s. And then in the 80s, 90s, 2000s, we started to see those rates go down. And if you split it by gender, we see that around 2000, rates from cardiovascular death had gone down in men, but they were kind of level in women. And so that really raised the concept that we really need to pay attention to both sexes. We want to decrease rates of cardiovascular disease in both men and women. And since then, we've seen a pretty substantial decline. So we've gotten better at treating cardiovascular disease. But if you look at the prevalence of cardiovascular disease, we haven't cured it by any means. The prevalence is still quite high. And so depending on your age group, the prevalence of cardiovascular disease can be as high as 85% in people above age 80. And so just because we've improved rates from cardiovascular death doesn't mean we've gotten rid of the disease. And so if you look at projected costs for healthcare in the US, they're projected to skyrocket in the next couple decades. And a lot of this is taking care of people with cardiovascular disease. That red line shown there is the rates of cost for hospital care. And so we know every time we admit somebody with a cardiovascular event, it's very expensive. It'd be in our best interest as a society if we can reduce rates of those events. And so when we talk about cardiovascular prevention, one of the things that actually has come to light in the last decade is the importance of this obesity epidemic that we're seeing. And so I showed you the graph earlier for rates of CVD going down. Just in the most updated results, we see actually a little uptick. For the first time, we have an increase in rates of cardiovascular death in the US in quite a while. And that's largely related to this obesity epidemic and to diabetes. And so we need to do a better job at cardiovascular prevention. When we talk about cardiovascular prevention, we also often divide it up into stages. There's primordial prevention, we call it, which is somebody who doesn't have any risk factors, who's young and healthy. How do we keep them young and healthy? That's mainly through lifestyle interventions. When we talk about primary prevention, that's people with risk factors who have not yet had an event that want to keep it that way. So somebody with a little bit of high blood pressure or high cholesterol, how do they avoid the heart attack or stroke? And then there's secondary prevention. That's people who have had a cardiovascular event and want to avoid a second one or a third one. And that's really where cardiac rehab comes into play. Cardiac rehab is kind of the basis of secondary prevention. It's the start of secondary prevention. Somebody's had an event, how do we keep them from having another event? It's incredibly important. And so when you look at what is cardiac rehab, it's really a total program. It's not just about exercise. It's education on lifestyle modification, and it's supervised exercise to try and transition you back into normal life after a cardiovascular event. It's supervised by a variety of healthcare officials, and it requires a physician referral. Not just anybody can sign up for cardiac rehab. It occurs typically in an outpatient setting, so either at a hospital or at a clinic, and they meet 2 or 3 times a week. There's 2 components. It's really exercise and it's education. And people, I think, often think about the exercise part of it. The educational component is just as important, if not more important, in my opinion. The exercise is supervised and people are typically monitored. So it's a nice way to transition back into routine physical activity because your heart rate's monitored, your blood pressure is monitored, your oxygen is monitored. It makes it kind of a safe setting to resume exercise. The educational part of it has multiple components: nutrition and mental health, how to return to work, medication and control your risk factors. All those things are very important as you transition back into normal life. They also look at help with smoking cessation, stress management, weight management, diabetes control, just a number of things that contribute to your overall health. There's multiple benefits to participating in a cardiac rehab program. And these benefits have been pretty well studied. So when we list these aren't just things that we theorize. We have clinical trials showing that when people participate in a cardiac rehab program, we see improved functional capacity. We see improved quality of life. People have better control of their risk factors. They have a better understanding of what's happened to them and why it happened and how they can avoid a second event. And they have improved capacity to perform their daily activities. These are proven benefits of the cardiac rehab programs. And in some of the larger databases, we even see improved mortality rates. People that do rehab seem to do better overall, including possibly even living longer. So as far as who is eligible, Medicare currently has covered kind of 6 traditional situations in the past with a couple of new recent ones. So if you've had a prior heart attack, you qualify for rehab. If you've had a stent or have had bypass surgery, you definitely qualify for rehab. If you've had any sort of heart surgery, including a valve surgery, it's another reason to qualify. If you have chronic chest pain from blockages in your arteries that can't be managed with stents or bypass, you can still qualify for rehab that way. And then obviously people who've had a heart transplant also qualify. Recently, congestive heart failure has been added to that list, which is a large population of the US. And so that's another group that qualifies, as well as people with blockages in the arteries that feed the legs or in blockages in the neck. So peripheral arterial disease is another reason people qualify. With private insurance, it's a little bit different, but typically if people have any of those 6 major conditions, they qualify. And now more recently, they're starting to recognize those other 2 conditions, heart failure and peripheral arterial disease as well. The cardiac rehab program is not just one person. It's a whole partnership of multiple people. You'll have a medical director who helps run the program, who you might have some interaction with. You have the referring physician who sends the person to cardiac rehab after their event. The program itself is typically run by nurses, but with the help of exercise physiologists as well to help guide the exercise program. The educational part is provided by the nurses, but we also see dietitians contribute, and social services and psychosocial services and pharmacists. It's a whole team that helps take care of you and transition you back into normal life after a cardiovascular event. Cardiac rehab is changing. We definitely in the past have seen mainly just building settings for cardiac rehab where it was always in-house where the cardiac rehab was performed. Similar to how exercise is starting to transition to at home as well with Peloton and some of these other companies, we're starting to see a lot more mobile cardiac rehab or virtual cardiac rehab. And in fact, we're kind of evaluating right now how we might participate in a virtual hybrid program where we actually have a building for cardiac rehab, but we also have virtual meetings where people do some of their rehab at home and do monitor exercise that way. And so I think in the future, this will be changing as we move forward. So this is a slide I frequently have as part of my nutritional talks that I give. And the reason that I include it is that right now, nutrition is such a complicated concept in terms of research. If you go on the internet, you type in healthy diet, you could read for a month straight and not know which way's up. There's so much anecdotal evidence out there when it comes to nutrition. You know, so-and-so ate this and they lost 10 pounds. Or so-and-so started this diet and they felt way better. You know, those anecdotal types of stories really don't help. They're not very helpful in determining what the science actually says about nutrition. It's really hard to do good nutritional research from a scientific standpoint. You know, most of these trials need to be placebo controlled, and you can't eat a placebo. You have to eat something else. So it all depends what you compare things to. It's hard to do these studies over a long period of time. They're very expensive. And so it's really hard to know what the science says about nutrition. And that's why I think the educational component of cardiac rehab is so important in programs is so important. They really help guide you towards what the science actually shows. And so just to kind of highlight how complicated that is, I want to talk about one topic in nutrition that you'll cover in cardiac rehab, and that's simply fat intake and cardiovascular disease. You know, this is where we've gone as a scientific community over the last 30 years. And even when we have scientists who are, you know, devoting their research to this, it still is complicated. And so having somebody guide you through all the things as far as what's true and what's not true, I think is incredibly important. And so if you go back 30, 40 years ago, kind of the conventional wisdom was that when people take in fat, their cholesterol goes up. When their cholesterol goes up, they get more heart disease. And it was kind of an intuitive concept. It kind of made sense. If you look at these plaques under a microscope, they're kind of fatty and full of cholesterol. And so this concept was adopted pretty quickly, even though we didn't have the best evidence to support it. A lot of the initial evidence came from something called the 7-country study, where this is actually researchers at the University of Minnesota here in town. And they looked at fat intake according to different countries and then their rates of heart disease. And what they found is that the countries that seem to take in more fat seem to have more heart disease, and they published that. And so it was a really interesting study, and it generated the concept that maybe that's true. But this is very much anecdotal evidence at just the country level. This is not a randomized trial. This isn't a controlled study. This is just simply looking at fat intake and heart disease. And so this should have raised the concept that this is something we should study. It doesn't confirm that this is true. But again, like I said, it's somewhat intuitive, and so we kind of ran with this. And when you look at the actual science, it gets a little more complicated. So if you look at fat intake and subsequent changes in cholesterol, when people do take in saturated fat, their LDL cholesterol goes up. This is changes in your LDL cholesterol here. This is your bad cholesterol level, according to how much fat you're taking in. And so you can see this is saturated fat here. As you take in more saturated fat, your cholesterol goes up. If you take in healthy fats, so these are your mono and polyunsaturated fats, so this would be like your olive oil, your nuts and seeds, and your avocado, that sort of stuff. When you take in more healthy fats, your bad cholesterol actually goes down. However, if you look at healthy fat or healthy cholesterol, like HDL, your good cholesterol level, as you take in different fats, your good cholesterol goes up with all three kinds of fats, but it goes up the most with saturated fat. Probably the best way to raise your good cholesterol other than exercise is to take in saturated fat. And so if you look at the total to HDL ratio, the ratio between the good and the bad cholesterols, when you take in more saturated fat, that actual ratio doesn't change that much. And that ratio is one of the better predictors we have in terms of risk. And so really saturated fat comes out looking a little bit more neutral than what we would have thought. It's not necessarily negative, nor is it necessarily a positive. We're not saying you need to eat more saturated fat to be healthy, but it seems to be a little bit more neutral, whereas healthy fats very clearly seem to be beneficial. And so since then, we've got some larger studies than that 7-country study, and some larger studies with a little bit more detailed information, so we can kind of do more detailed analyses. And so this is data from the Nurses' Health Study, which was over 77,000 nurses who signed up to be part of a research study, followed for 20 years, so a really well done study. And they simply divided them up into fifths based on how much fat they were taking in at baseline in their diet. And this is their relative risk for a heart attack or for heart disease. And so what we'd expect to find, based on the older data, is that as they took in more fat, we should see their risk go up for heart disease. But that's not really what we see at all. We see that as they take in more fat, the risk of heart disease doesn't change very much. And if you look at saturated fat, again, stays pretty neutral. It doesn't seem to increase the risk very much. If you look at different food groups, we kind of see the same thing. This is a meta-analysis, so kind of a lumping together of all the research that we have for meat intake, red meat intake mainly. And so they split it up into processed meats and unprocessed meats. And so for your processed meats, which is your ham and sausage and bacon, things with a lot of salt in them, we do see an increase in risk per serving per day. So if you're eating bacon every day, your risk of heart disease does seem to go up. But if you look at unprocessed red meats, it seems to be a little bit more neutral. The relative risk comes out at 1.0, which is basically no difference. And so that's your roast and your hamburger and your steak. Again, it's per serving per day. And so, a reasonable portion of red meat once a week, that doesn't necessarily seem like the worst thing. We don't necessarily promote it as a way to be healthier, but it's not necessarily a complete negative either. If you look at dairy products, we go through a lot of food fads, and currently in the keto paleo world, there's a lot of, humans aren't meant to take in dairy once they're older. Well, if you look at all the studies that we have, the people that take in dairy don't seem to be less healthy. In fact, they seem to be maybe slightly healthier. When you lump all the studies together, this is again a relative risk study. On the bottom side here is lower risk, and on the higher side is higher risk. If you look at for stroke and for diabetes, we see overall a reduction in risk for those things in people that take in more dairy. And this is including full fat dairy. This isn't just low fat dairy. And so for yogurt and cheese and fermented dairy products, we seem to see evidence of health benefit to them. And for your neutral or for your non-fermented products like milk and other dairy products, it seems to be a little bit more neutral. And so again, the idea that the main thing you want to avoid in your diet is fat, I think over the last 30, 40 years, we've seen that's definitely not the case. And one of the issues that we run into is that, well, if we tell people not to eat something, they're going to eat something else, right? Nutrition is very substitutional. If you take something out, something often gets replaced. And so one of the interesting studies look at in this large database of people, this was over 300,000 people, if you take something out of your diet, what do you replace it with? And subsequently, what happens to your risk for heart disease? And so this is, what about people that take saturated fat out of their diet and replace it with polyunsaturated fats, with healthy fats? This would be like going from butter to olive oil, that sort of thing. Well, the relative risk of heart disease seemed to go down in people that included more healthy fats in their diets. That makes sense. Well, what if you take out saturated fat and you put in carbohydrates? The risk actually seemed to go up a little bit. And if you divide it into different kinds of carbohydrates, it all depends what kind. So for your low glycemic carbs, so this would be your whole grains and your vegetables, people's risk actually seems to go down the more they include those in their diets in place of saturated fat. If you look at medium glycemic carbohydrates, like your whole vegetable or whole fruits, stuff like that, it's a pretty neutral change. It seems to be slightly better, in fact, to take those in. But if you look at high glycemic carbs, so this is your white bread and your white pasta and your white rice and your sugar sweetened beverages, we see a very clear increase in risk in people that took out saturated fat and replaced it with those things. And if you look at the US trajectory of nutrition in the past, our low-fat yogurt, our low-fat ice cream, our low-fat mayo, all those dairy products that were made low-fat, they took out the fat and they put in sugar. That is not a healthy substitution. That's not something we want people to do. Additionally, those are observational studies, and so we always take those with a grain of salt. We never quite know how to interpret those. And so we are fortunate enough, we have two really large randomized trials, the best kind of evidence that we have that look at diet. And one of the first ones was a low-fat dietary pattern. So this is a women's health initiative. This is around 48,000 women who were interested in getting healthier. And so half of them were randomized to a low-fat diet. They were told to eat a low-fat diet and avoid saturated fats at all costs. The other half were told to continue eating the diet that they had before. And it was a 10-year study, so a very large, very well-done study. They did a bunch of food frequency questionnaires, and the people in the intervention group seemed to actually follow through on what they were told to do. They seemed to actually follow a low-fat diet. And over 10 years, it didn't seem to make them any healthier. They didn't seem to have less heart disease. They didn't seem to have less strokes. They didn't seem to have less diabetes. None of the kind of effects that we would think people would have from eating a healthier diet, we didn't see any of those things. And so a low-fat diet has been pretty well tested, and it doesn't necessarily seem to be the healthy way to eat, especially when you consider healthy fats. We want you to have healthy fats in your diet. And in fact, we have a trial looking at healthy fats. So this is the Med study. This is from about 7 years ago now. It was done in Southern Europe and Spain. And these people were given, as an intervention, a quart of olive oil a week and said to use it as much as they want. And they make a lot of sofrito there, and so they use that in their sofrito. And so a quart of olive oil is a ton of fat. In fact, I think in the analysis, they said over 40% of their calories were coming from fat. So it was a very high fat diet, but it was a high healthy fat. And so what that Med trial actually showed was a reduction in heart attack and stroke in the people that received the higher dose of healthy fats. They received the olive oil, like I said. They also received nuts and seeds, so things with high healthy fats. And so this is really the only randomized trial we have in nutrition that showed an improvement in cardiovascular outcomes. And it was by including more fat in their diet compared to a group that was told to eat a relatively healthy, low-fat diet. And so to me, the evidence is very clear that in our current era, this Mediterranean-style diet is the one that keeps on winning, and it keeps winning for a reason. We want a diet that's high in healthy fats, a diet that's low in simple carbohydrates, a diet that's clearly high in fruits and vegetables, and it might have some saturated fat in it in moderation. And so there's always these fad diets that come and go, but I think those basic themes are going to continue to persist, and that's the ones that really the science shows. And so I think being part of a cardiac rehab program is helpful because people get bombarded with nutritional information all the time. And so having somebody to help kind of sort it out for you, I think is really helpful. And then the second part I want to talk about is medications, preventive medications. And this is a very important topic. And I talked about, the exercise part of rehab and the educational part of rehab. To me, the most important component of a cardiac rehab program is just simply helping with the transition back into normal life. If you look at people in this first 6 months after a cardiovascular event, and I know Dr. Bachler is going to be talking about stress and that component. I don't want to rain too much on that parade, but or not rain on her parade, but I don't want to intervene too much on her talk. Going from a world where your last thought on your mind is about your heart to a world where one of your first thoughts on your mind is your heart, it turns out those are very different worlds. And transitioning back to normal in that second world is tough. If we look at the rates of fatigue and the rates of insomnia and anxiety and depression and just not feeling well and being achy and sore and not being able to do stuff, those rates in those first 3 months after a procedure, after an event, are very, very high. And they're high in pretty much everyone. They're not guaranteed to happen, but a lot of people just don't feel well right away. And so quite often the medications kind of become the scapegoat. They're like, it must be all these new meds I'm on. They're causing all the problems. Well, if you look in the trials, it's a little bit different than what you'd think. And so this is one of the bigger studies for rosuvastatin. This is the Jupiter study. This was published a little over a decade ago now. And it was a pretty simple trial. It was people who were pretty low risk, actually, overall for heart disease. They had pretty normal cholesterol. They had slightly elevated rates of an inflammatory marker, which is a little bit of a risk factor, but not a super high risk group. And it was simply half of them got rosuvastatin and half of them got a placebo, which looked like rosuvastatin, but it didn't have anything in it. And what they found pretty clearly is a pretty substantial reduction in cardiovascular events. The people who actually got the rosuvastatin, they had a 44% reduction in heart attack, stroke, getting a bypass or a stent, or dying from heart disease. And so the trial was actually stopped earlier than what they thought because the benefit was so significant. And so coming out of this study, there was kind of a call for saying, hey, maybe we should use these medications more than what we already are. The issue is there's always concerns about side effects. Patients say, I don't want to take anything that's going to make me feel poorly. And unfortunately, we kind of live in the era of misinformation. And so if people go to the internet and they type in, should I take a statin? I did it yesterday, in fact. And this is what came up pretty quickly. This was like the third or fourth thing on the list, is that watch out, statins can be really dangerous. And there's whole websites that are devoted to how dangerous statins are. And part of that comes from one of the first statins being a bad drug back in the 1990s, Baycol. And that drug got removed pretty quickly because it was a bad drug. It did have some issues. But ever since then, there's been a lot of concern that watch out, these statin medications can really cause harm. And part of that, the supplement industry uses that as kind of a marketing campaign, saying, watch out, don't take those statins, don't take those medications the doctors prescribe, take our natural stuff instead. And so we have a lot of patients that come in to a clinic and say, I really want to just do things naturally. Arsenic is natural and cocaine is natural. There's a lot of natural things that aren't healthy. The goal isn't to be natural. The goal is to be healthy. I don't want to give anything to a patient that does them harm. I don't want them to feel poorly. And so if we thought a statin caused them harm, we don't want to give it to them. If you go back to that trial, though, this is that Jupiter trial. They also keep track of the rate of side effects. They keep track of the rate of adverse events. Again, we don't want to do harm. And if you look at the rate of adverse events, it's pretty similar in both groups. Kind of any serious adverse event over the 5 years of the trial happened in 15% of the patients on rosuvastatin. And in the placebo group, it was 15%. It was exactly the same. The rates of feeling sore or achy or stiff was 16% and 15.4%, pretty much the same. The rates of cancer and kidney problems and stomach problems and liver problems were all exactly the same. There was no increase in side effects. And in fact, if you lump all the trials together with the newer statins, we don't see any evidence of any harm. And some of the trials are up to like 20 years now, to the point where there's been talks about moving them over the counter. And so we have all this safety evidence for statins, but yet we have a lot of patients that have concerns about whether or not they're causing side effects. And so it's really helpful to have a cardiac rehab program with you there to walk along you and say, hey, this is the actual risk of the medications. These are the benefits. There's fatigue going on right now, but maybe it's something else. And it's a tricky conversation with patients because I think it's very easy for the patients to hear, the doctor's trying to tell me these are in my head. No, that's not the case at all. The symptoms are very, very real. It's just a question of what's causing them. And we don't want to unnecessarily blame it on the medication because we have really clear evidence of benefit. If we look at somebody that's had a bypass surgery, for instance, the main predictors are how much damage was done to the pump, how a person takes care of themselves afterwards, and if they stay on the medications. And if they stay on the medications and take good care of themselves, the risk of a recurrent event is quite low. So to finish up, I was just going to present you a case that kind of encompasses cardiovascular prevention. It's not necessarily a cardiac rehab case, but it kind of fits in with the concepts of cardiac rehab. And I bring it up as anecdotal evidence. Like I said earlier, we have a lot of anecdotal evidence out there, which sometimes can be misleading. This is some positive anecdotal evidence, I think. And so it's a case that was published a couple years ago. It's a 42-year-old gentleman in Boston who had a history of high cholesterol. It wasn't terribly high, but just kind of mildly elevated, but also had a family history of early heart disease. And he showed up to his doctor and he said, over the last 4 months, if I climb a couple flights of stairs, I start to notice a chest pressure. And when I get to that top flight, it gets to be pretty severe over the last couple of weeks. It's getting worse. And so they said, well, it sounds concerning. Let's do a stress test and check it out. So we got a stress test, and you don't necessarily need to be a cardiologist to read this. Basically, you're comparing the donuts, which is the heart here, and the perfusion of the heart at rest, and then the perfusion of the heart at stress. And as you can see over here, there's part of the heart missing at stress. It's not getting enough blood flow at stress. That suggests there's a blockage in the artery that feeds that part of the heart. And so what they did is they decided to do a CT scan to kind of further investigate. And what the CT showed is a blockage in one of his main arteries. And so this is a CT coronary angiogram. So here's the aorta coming up out of the heart. Here's the aortic valve. And then here's the left main coronary artery, and it splits into a branch. And right there at the beginning of that branch, we see a blockage. There's white calcified plaque there and some dark soft plaque there. And this is just another view of it. It's a severe blockage in this artery. And this artery is what feeds the part of the heart that was abnormal on the stress test. So this all fits together. They told the patient, you have a blockage in an artery. We should probably do an angiogram and put a stent in, and I think we can make your symptoms better. And he said, I'm really young. I don't know if I want to stent this early. Is there any way we can do medical management? Can we try medicines first to see if that makes it better? Most often, that's not what would be done. Most often, someone would go to an angiogram in this case and get the stent. But we do have some studies showing that that's a safe alternative. And so he decided to go the medical route. And so he started a cholesterol-lowering statin. He started ezetimibe, which is a different cholesterol medication. He went and saw the dietitian, and then they said, let's slowly work on increasing your level of physical activity. So this is kind of a basic cardiac rehab program here. He did it on his own. And over the next 3 months, his pain went away, and he felt better. And his cholesterol came way down. He lost some weight. His blood pressure came down, and he felt much better than what he had before. So they said, all right, great, we'll keep the medical therapy going. And about 3 years later, he had some recurrent chest pain. This was very different. It wasn't exertional. It was kind of sharp over on his left side. It didn't sound too concerning. They said, well, given your history, let's just repeat that stress test and see where things are at. And so when they repeated it, it was completely normal. The previous area of ischemia, the previous area that wasn't getting enough blood flow, had completely normalized. And so they decided to repeat his CT scan, and that artery that previously was blocked up is now completely open. some of that calcified plaque didn't go away, but the soft plaque all went away. And that's what we know what can happen. If you treat yourself aggressively, we can see regression of the soft plaque that's there. It starts to dissolve. And so this artery that was previously severely diseased is now, for the most part, wide open. And so this is really the benefits of a cardiac rehab program long-term, right? People that control their risk factors, people that eat a healthy diet, people that exercise clearly do better from a cardiovascular standpoint, and they do better because it can reduce plaque. And so seeing it with your eyes, I think sometimes really helps to understand what the real benefits of this are. We know very clearly a stent or a bypass can be life-saving, but it's what you do after that event that really matters as well. And so there's a comparison of the two vessels. Again, you can see the previously blocked artery is now wide open. So I hope you found that a benefit. I hope you enjoy the rest of the day, and I'll try and hang around for the question and answer period. Thank you.